Hi there, and many thanks for inviting me to participate in this session. I'm sorry I can't join you in person, but I'd like to spend some time, if I may, just with the background I have of being a tummy specialist, gastroenterologist, who's done a lot of work with patients who have nerve and muscle diseases, to try and present some of the outline of what happens to patients and what we can try and do to help them, just to give a sense of actually that these are a set of symptoms which are common, but also which are symptoms which we can try and help with. They're not necessarily just pointers to discuss because there's nowhere to go with them. I hope that I can give some hope that actually some of these symptoms, which can be very burdensome, can be addressed at least partially to be relieved if possible. And I say this in the context of the fact that obviously, as everyone joining this session knows, gastrointestinal or GI problems are a small part of the burden facing patients and families and carers with Duchenne and other neuromuscular diseases. It's one component, but I would say it's also a very important component. So whilst it may not be directly life-threatening in the way that heart and lung things can be, it has an enormous impact on quality of life, as we all know how important it is to be able to get nutrition in and to have that sense of control over our own guts. So if we think about the gut as one long tube from your mouth down to your bottom end, unfortunately, adults and children with Duchenne's can get problems throughout that length of the gut. And it can begin at the very top end, especially with swallowing difficulties. And swallowing difficulties have a huge impact, obviously, because you can't get your nutrition in, but also with the hydration, but also dealing with saliva. And so you can see that the things that we are looking out for, and a lot of you will be very familiar with, having been asked about many times, is about weight loss and weight change and how difficult that is to measure, of course, and about how long it takes to consume food. Sometimes we can manage to avoid losing weight, patients and families can, but it takes an inordinate amount of time to do that, and there's a huge sense of fatigue after meals. Sometimes it can be that actually the first warning sign is that saliva can't be dealt with properly, so you get that kind of very wet voice, which you may have heard some patients describe. And of course, at the worst end, the thing we're trying to avoid most is if food or other material starts getting into the lungs, and that can cause sort of dramatic presentations with pneumonia, or even more worrying in some ways is when that happens gradually and there's a progressive loss of lung function, which may be due to, at least in part, gut symptoms which are not being recognized. And that is important because actually the mechanism by which we swallow, this is just a figure to illustrate what I'm saying, but not to go through in detail, is enormously complicated. That interplay between the voluntary part of what we do with our mouth and our lips and our throat, and the involuntary part where your body takes over for that green globule shown in this image to pass down the system. And what I want to do is tell you that there are things we can do about this. We can make measurements in various ways to define these abnormalities. We can make very clear, accurate measurements. And then we can support patients. It's not just a question of finding out that this is there. We can then support patients in very direct ways. We can make improvements by addressing the particular needs of the individual. There isn't a single version which sorts every patient out. Every individual has different needs, and so about a third of our patients may need ventilation, but only a small minority of those actually have problems with reduced weight. Other patients may find that certain foods provoke symptoms and develop intolerance to certain food, and we need to try and handle that through dietetic input. And generally people tend to find that smaller meals with less fiber and less fat, so less cereal and less fatty foods, can be tolerated better. And what we're trying to do is to provide enough nutrition without having to give any supplementary feed if possible. And by doing that, that means essentially focusing on the nutrient intake, the electrolytes, the little minerals that are important for your body, which you need and get naturally from foods when they can be given. But sometimes some of the diets that we move into can restrict that, so we just need to keep an eye on that, and of course making sure that we get enough liquid in, but not so much that we end up with the patient not being able to manage bladder function in a sensible way. So there's really a So it's a fairly complicated and very individual is the key point I'm getting at. And that is why it needs a tailored approach to all this. And ultimately, all we're trying to do is trying to prevent the complications that go wrong when you don't get enough nutrients and electrolytes into ourselves in terms of immune function and strength and sort of the interest in life that comes from being able to nourish oneself. Now, abdominal bloating is something that patients and families notice a lot, and sometimes there are things that we can identify with this. We can do some tests to look for whether there's something called SIBO, small intestinal bacterial overgrowth. So because the muscles of the gut move slowly, they can get colonized, and we can measure this by doing a breath test. That can be a little tricky for patients with poor respiratory function because it needs them to be able to breathe into a little bag every so often. But we can identify when there is bacterial overgrowth. And if we can't do the test, sometimes we suggest actually just treating because it's there. But of course, we have to be careful with just giving antibiotics blindly. But the point I'm getting at is that we can try and assess that. Oftentimes, I have to say that overgrowth is not present when you have a bloated patient, and it's just part of the loss of muscle tone with the abdominal wall then becoming distended, and there's not much one can do about that other than to recognize it. But sometimes that can be due to the fact that the abdomen, that can cause problems, should I say, where the diaphragm gets a bit stiff because the tummy is so bloated, and that should then make us think about the other things that can be going on. And this complicated figure is one we drew up with a variety of colleagues, dietitians, physiotherapists, nurses who work with neuromuscular patients. And what it tries to do in the vertical lines is to point out the symptoms that patients have. On the far left, in pale blue, the upper gut symptoms like nausea and reflux. In the middle, the abdominal symptoms like pain and bloating. And the last section on constipation and diarrhea, the bowel symptoms. And then in the horizontal rows, it describes the approach we take of how we assess patients, and then how we can identify the causes, how we can help them with nutrition, and then what we can do to treat them beyond nutrition. So it's kind of a grid approach, and of course it makes it seem very simplistic, like all patients are the same, which I've said many times they're not, but just to make sure we try and dot all the I's and cross the T's. But the point I wanted to make from that, if that's okay, is that actually if you look at that first line in a bit of detail, so what it shows is that constipation is one of the most important things for all of those symptoms, whether it's heartburn, reflux, abdominal discomfort, bloating. Constipation is a thing, and constipation is actually, it's quite complicated, and I've put this little cartoon in there to try and make it the complexity of it a bit simpler, which is that it depends on having the bowel in a full enough state in the lowest part of the bowel, and then being able to sense when that part of the bowel is full, and then being able to squeeze that, and then being able to control when we stop squeezing it, and then to also be able to make sure that what is down there is neither too soft nor too hard. So it depends on a lot of factors which we have variable levels of control of, and you can see therefore why these symptoms can be quite difficult to manage when they occur in some patients with muscular disorders. So we assess that by taking a diary history, because usually a single snapshot of one day isn't a very good reflection of what's happening to bowel function. We try and look at it over a week or two. And then we have a pathway where we start off with the simpler options, we move into more interventional ones, and then we have some very rarely needed and very rarely used in this population, very invasive ones. But the point I want to get at is that for most patients, we're able to manage them in that green zone of this pyramid. That's where the thickest part of it is, that's where most patients are managed. And there are things we can try and do, and they're listed on this, not to go through them in detail, but to give that sense, as I say, that there are things we can do for patients in this situation. So final slide. There are things we can do, but there are many things we don't as yet know. We don't know how common these problems are. We don't actually know what generally patients and carers want, and I hope that this kind of exercise we're engaging today begins that dialogue where we can almost begin to get a shopping list of the things that matter most to patients and their families. We'd like to know a little bit more about how to assess nutritional needs in patients with Duchenne's, and maybe even think about tailoring a field which is a general cover-all for many individuals. We need to think about how we transition dietary change, and we also need to think about where nutrition fits into this. And then finally, which I haven't put on the slide, is think about how the how do we get constipation treatments in a way which is suitable for families and patients who generally find themselves very much chair or bed bound as the disease progresses? How do we manage bowel function in a satisfactory way to give dignity? So lots of things we don't know, but the point I guess I'd like to emphasize is that there are things we can do, and that's key to try and begin the conversation, not to expect that everything can be sorted out. One does one's best, but to try and at least begin to voice that so we can see bowel symptoms as part of the general holistic package of care that's needed. Thank you very much.